Hello to you 83 beautiful subscribers. Let's talk about massage. Now there's all kinds of names that people use for this kind of therapy. Massage, myofascial release, soft tissue work, trigger point therapy. But it's basically all just some kind of tactile touch that is used to relieve pain and supposedly improve function. It falls, in my opinion, under the umbrella term of manual therapy. Now, manual therapies are commonly used by all types of physicians and therapists, like physios, orthopedic surgeons, chiropractors, sports therapists, osteopaths, etc., etc. And it's basically a type of passive, hands-on modality that is used on a patient by a clinician. And this also includes things like manipulations and mobilizations. And I never use them. Well, I shouldn't say never, but I rarely ever use them on a patient or recommend them. And if that situation does arise, I'll always make sure to explain what it is and what the patient should expect from it. And that is nothing much, other than some type of short-term pain relief that probably won't even last longer than an hour. So why am I so skeptical when it comes to manual therapies? Well, firstly, it is simply because mechanistically it makes no fucking sense. Our anatomical bodily structures are very strong, very robust, and I believe that logically, manual therapy and massage would make no difference to them. Furthermore, we have studies to show that you actually need thousands of newtons of force or something like that to impose a physiological change in structure to a muscle or a tendon or fascia, that of which is impossible to achieve with a clinician's hands. So if somebody's telling you that they're breaking up scar tissue or adhesions, they're talking utter nonsense. And secondly, it's also impossible to reliably assess dysfunction in our tissues with palpation or touch alone. What I mean is the whole phenomenon of trigger points being a musculoskeletal disorder that is found in our tissues simply does not exist because, again, in research, each different treating physician will have a different finding of trigger points on the same patient, even when the method used is standardized. So one therapist may identify a trigger point in your neck and not in your shoulder, and then another therapist comes along and they find a trigger point in your shoulder and not in your neck, for example. At the same time, even the treatment methods are non-specific. For example, you may be familiar with chiropractor's manipulations or manipulations that are most commonly performed by chiros. Even those have been found to be non-specific, meaning they do not specifically affect the target tissue that they claim to be treating. So if a chiro clicks your back, claiming they are manipulating the L4, L5 vertebral joint in your spine, the chances are that they'll never be able to isolate L4, L5 alone, and the application of force will affect all the adjacent structures around it. So bear that in mind when I tell you that it has also been found that all of these or many of these manual therapies do not even need to be administered by a specific therapist to yield better results. So regardless if you're massaged by a sports doctor or somebody with a diploma in massage, your outcome is likely to be identical. So if these treatments can't release adhesions like people say they do, they can't break up scar tissue, trigger points aren't a reliable diagnosis, the treatments are non-specific, and the effects are usually short-lasting, how come some people still find favorable results with them? Well, it's very nuanced and not entirely understood, but there are many confounding factors at play that I believe may contribute to the positive outcomes experienced after manual therapy. The first is that the pain relief experienced is likely to come from some sort of neuromodulation and not an alteration in the tissue itself, a type of sensory input that influences the nervous system activity and thereby affecting our interpretation of pain. And this goes hand in hand with what we call the pain gate theory, where a non-painful sensory input, like massage or heat therapy, can affect larger nerve pathways and therefore closing or blunting the painful input from traveling to the central nervous system. The biggest factor, I believe, is the context surrounding the treatment. and the expectations presented by the clinician and the patient. Basically, if a patient is led to believe that the treatment will help them and expects that it'll assist in their recovery, then it is likely that they'll respond positively to it. At the same time, a lot of conditions and painful ailments tend to resolve with time, what we call natural history. And there's a quote that says, "The art of medicine is entertaining the patient while natural history cures the disease." And I think there's a lot of truth to that. So the way we present ourselves and present our techniques is tied to clinical outcomes. The magnitude of a response may be influenced by the mood or the expectation and conditioning. Basically, it's a very roundabout way of saying it's a placebo. So to end it off, I'm not necessarily saying that manual therapy is evil and should be avoided, but I think it should be communicated and understood openly. A lot of beliefs surrounding adhesions and tight muscles and trigger points can lead people into a very negative, nociceptive spiral that can sometimes worsen symptoms. So we need to be more knowledgeable and open into what these things are and stop perpetually reinforcing dogmatic beliefs to our patients to justify treatments of which we have no understanding on how they work.